Great. Thank you, Pete and Linda. And good morning, good afternoon, and good evening for all the participants today. I'm going to talk about orbital and ocular trauma in basketball. And this is my preview. I'm going to talk about a review on the orbit and ocular anatomy of the eye. And we'll talk about ocular trauma and how orbital trauma, and the end, we'll talk about the eye injuries in basketball, how we evaluate, and the best way to manage. Review on the orbital and ocular anatomy. This is a very busy slide, and what concerns us are few things. This is the eyelid crease, which comes a little bit like 10 millimeter above our eyelashes. It's an important landmark. If we have a trauma, if we want to suture, if we want to do anything, it's very important that we follow the path of this eyelid crease. Okay. So this is our eye. This is the skin. And then if we remove the skin, we have the orbicularis muscle, which is a round muscle around the eye. You have the frontalis muscle, which elevates the eyebrow, and so many muscles that you don't have to go through that except if you are an ophthalmologist. We go now deeper. This is the muscles we talked about. This is the procerus muscle, which is important for our frowning. This is where the ladies will do Botox sometimes for that. And then you have the orbicularis oculi muscle, which is the round muscle. Okay, this is the color. This will help us to close the eye. We go inside, we have the septum, and then we have the fat. We have two fats in the upper eyelid, 3 fat tissues in the lower eyelid. And this is our lacrimal gland, which is in the upper lateral part of the upper eyelid. And this secretes the normal tears. It's the normal tears, which is water, and not the exact tears that we need. Going inside more, this is the levator muscle that elevate the eye, and this is the inferior muscle that will depress the eyelid, actually elevate the eyelid and depress the eyelid. Another important structure on the medial side of the eye is the lacrimal apparatus. The lacrimal apparatus is different from the lacrimal gland that I said situated up on the lateral side. The lacrimal apparatus, it comes on the medial side. We have an upper canaliculus, lower canaliculus. They come and join at the nasolacrimal sac that would open in our nose and under the inferior turbinate. It's important to know the anatomy of this if we have any injury during the game. This is a sagittal cut of the eye. And this is the upper eyelid. We have the skin. We have the orbicularis muscle. We have the tarsus, which is a hard cartilage structure that help us to elevate and invert the eyelid. And we have the conjunctiva inside. The eyelid, as you see, it protects our eye. This is our eye. This is our cornea. Okay, so the eyelid protects our eye. We have 7 bones that forms our orbit where the eye is situated. We have the frontal bone, the zygomatic bone, the maxilla, lacrimal, 2 ethmoids, a small bone called the pterygoid, and the sphenoid. It's very important to know that the weakest muscle, the weakest bone in our orbit are the ethmoid bones. Okay, so this ethmoid bone is very, very weak. Now going inside, we see that all our extraocular muscles that move the eye, they originate from the bone in the orbit. It's called the annulus of Zinn, where we have so many nerves and vessels that go through, except the inferior oblique muscle, which originate from the lacrimal crest. This is schematic drawing of the eye. This is in the front. You can see the cornea. And this is called the sclera, the white. and the attachment, it's called the limbus. Important to know the limbus because if we have injury, to know when to refer. And we have the extraocular muscles. We have 4 straight muscles. We call them the recti. We have one that elevates the eye, one that depresses the eye, and we have one moves in and out. And we have 2 oblique muscles that will cyclovert the eye. So go back. I'm really sorry, giving more anatomy, which is important. This is your cornea, your sclera. This is the iris. The opening of the iris is our pupil, and behind it is the lens of the eye, which all of us at an old age, we will develop cataract because of the opacification of this lens. This lens is attached through zonules. So these are ropes. During trauma, these zonules may be disrupted and the lens may be disrupted. So it's important to know the anatomy of this structure. Behind the lens is an aqueous gel, which is made up of water mainly, and it attaches to a very important structure called the retina. This is the retina, and all the retinal fiber nerves will come and they will go out through the optic nerve and go back to the brain. The sharp image that we take when we look is through the fovea or the macula, which is a small depressed structure directly near the optic nerve head. This is a huge schematic drawing just to tell you that the nerves for vision comes from the posterior brain. They come through the brain and then decussate on our gland, which is behind in our brain, and then one fiber will go to this side, one fiber to the other side. The retina is a neurologic tissue which is made up of at least of 9 layers. We don't have to know that. Now we go to the good part. So the anatomy I just finished. I'm going now to talk about ocular trauma. We start with the eye examination, go to the eyelid examination, then to the periorbital examination. An injuries to the globe, to the eye, can be a closed injuries, or they can be an open globe injuries. In closed injuries, it can be contusion, it can be lamellar laceration, or a superficial foreign body. In an open injuries, we may have rupture, laceration, intraocular foreign body, penetrating injury, or perforating injury. So this is a patient who had a trauma. It's a closed injury, and he had blood coming on the lateral part of his eye. This is called subconjunctival hemorrhage. It's under the white above the sclera. You have blood in this area. Traumatic subconjunctival hemorrhage can be related to trauma as minor as excessive eye rubbing, or as an extreme as an open globe injuries. It resolves in days to weeks if extensive. Treatment is very easy. We just lubricate the eye, we assure the patient, and we tell him do nothing except use artificial tears. Corneal abrasions. It results from the disruption or loss of cells in the top layer of the cornea. This is our cornea. Cornea is made up of 5 layers. The top layer is called epithelium. It's a 5-cell layers. The good thing about it, it regenerates in 24 hours. So we don't have to worry. When it happens, it causes discomfort, foreign body sensation, severe pain, eye erythema, photophobia, and light sensitivity. This is, we use fluorescein. At the end of the lecture, we'll tell you how to do that on the court, and the pin light to see the abrasion. Treatment is only topical antibiotics 4 times per day. Very important when you have a corneal abrasion and you are treating for 1 week or 5 days, it's proper hygiene, and always use lubricating artificial eye drops. Now we go to a corneoscleral lamellar laceration. So you see the laceration is not central, it's from the cornea all the way to the sclera, and it's lamellar, it's still superficial. It's a shallow, partial thickness laceration. Also can be managed conservatively with a soft bandage contact lens with or without tissue adhesive. Also treatment is topical antibiotics and artificial tears. This is the fluorescein that we put to see the abrasion, and we see that it's a closed trauma and not an open trauma. Scleral rupture. Rupture injuries can be associated to varying degrees of expulsion of the intraocular contents. So this is more serious and it's more important. The most common location for rupture is the limbus. I told you about the limbus. It's the corneoscleral junction between the cornea and the sclera. So if you look over here, you see that there is blood inside the eye. There is something abnormal in this area. And if we look carefully under the microscope, we can start to see some blackish material coming out in the white matter. And this is part of the choroid or the retina coming to this area. Okay. We know that our pupil is round, regular, and reactive. Any trauma may cause a disrupted shape of the pupil, and this is a traumatic mydriasis, which means a dilated and also is an irregular pupil. It results from the iris sphincter tears that alter the shape of the pupil. It may be associated with blood in the anterior chamber, and important that the pupil changes are usually permanent. And having a pupil which is dilated all the time may cause the patient to have severe photosensitivity. This is blood, severe blood in the anterior chamber. It's injury to any arteries supplying the iris of the eye or the ciliary body. It can be small, as we saw in the other slide, or it can be that much. The treatment for this patient is relative bed rest, giving medication that will lower the pressure inside the eye, dilating their pupil, giving steroids. And if it stayed more than 2-3 days or caused very high pressure, then surgical evacuation has to be done. Also, trauma may cause traumatic cataract. It can occur directly or as a later on, involving part or the whole lens. We know that the lens is surrounded by an anterior or posterior capsule. Any trauma may disrupt the anterior or the posterior capsule. Like this patient, the anterior capsule has been disrupted. This is the lens of the eye. Instead of being posterior to our iris, it's anterior to our iris. This is an emergency cataract removal surgery needed. This is a patient who got trauma and the lens of the eye, instead of being in the center, I told you in the anatomy they have like ropes covering. Instead of having these ropes covering, they are disrupted. So you have subluxation of the lens, and the lens, it goes posteriorly and not anteriorly. Posterior vitreous detachment. I told you there is a vitreous, which is water, which is present between the lens and the retina. We can have a detachment of this material. It's separation between the vitreous cortex and the retina neurosensory part. It's a normal thing to happen. Most athletes have them. They will tell you, when I look in the sun or from far, I see few dots or few lines are moving. As long as they are moving, then we have no problem. The problem we will face if it becomes like a cloud coming in front of their view. Okay, vitreous hemorrhage. Now, it's not only detachment of the vitreous, you have blood in the vitreous area, and that comes from rupture of the normal vessels. Okay, it can be an acute posterior vitreous problem, or if you have hemorrhage in the brain, may cause hemorrhage in the vitreous, and this is called Terson syndrome. Sometimes we see it with a patient with trauma to the head with a loss of consciousness also. Commotio retinae is the damage of the outer retinal layers. It's caused by shock waves. It causes intracellular and extracellular edema. This will assure the patient because the recovery is very fast. Choroidal rupture. We rarely see it, but we see it in basketball trauma if it's direct to the eye. It's a tear of the choroid and the Brooks membrane and many tissues in the retina. There is no effective treatment. We have to wait for the blood to go away. Retinal breaks. Is there any full thickness defect in the neurosensory retina? It can be small break. I don't know if you can see it over here. We have blood in this area, and there is this retinal break. And this break, if it happened from trauma, relative bed rest, and directly the patient need to have laser. If it didn't help the laser to seal the break, then we do surgery for them. Macular hole. Direct trauma to the cornea may cause a hole in the macula. The patient may lose central vision, and this is how it looks. This is called OCT, which is CT scan of the eye. This is a patient recently, last month, came to me with a direct trauma to his eye. Referred from a tertiary hospital, they told him a relative bed rest. They told him, no, we have to explore. And by exploring, the trauma caused a big rupture in the sclera all the way to the retina. Even though we did surgery, the patient now is no light perception in his eye. So any small trauma to the eye, if we're not able to manage, please, we have to refer. Rarely we see it. If the player puts his hand inside the eye of other player and forcefully pull it up, he may dislocate the optic nerve. Total loss of vision characteristically occur in these patients. I finished from the ocular trauma. I will go to the orbital trauma. Soft tissue injuries. They are classified as contusion, abrasion, avulsion, puncture, or laceration. It can be simple, it can be complex, it can be superficial, it can be deep. The location is very important. In the anatomy slide, I talked to you about the lid margins. I talked to you about the canaliculus. So this is a simple eyelid laceration. We see it in a lot of basketball games. A small trauma to the orbit area may cause only skin, and you can see part of the muscle. Why it's important? These patients, if the eye examination on the court is normal, you can either suture it or put a steri strip, and if needed, the player can go back to the game. However, if you have a complex laceration, including fat and the eyelid margin, or in the medial side, we said we have the canalicular system that takes the tear, or if you have a huge laceration, then do nothing, put an ointment for this patient, and refer to an oculoplastics. Blowout fractures. Any impact to the orbit raises the intraocular pressure to the point where thin bones, we talked about them, these are the ethmoid bones and the maxillary bones. They will push the orbital content through a trapdoor in the maxillary sinuses. The orbital rim will stay intact. Symptoms will include double vision, because the muscle which pulls the eye down is affected, and hyperesthesia, because there is an infraorbital nerve that comes in that area. You can have epistaxis, which is blood in your nose, restrictive deviations. He cannot pull the eye up or down. The eye may go in, we call it enophthalmos, and subcutaneous edema or emphysema. So this is our patient. The trauma is here. He can elevate the good eye. He cannot elevate the other eye. If we do a CT scan, this is the fracture, and this is the content of the eye going in. This is called the trapdoor for the inferior rectus muscle. This is an emergency anorbit compartment syndrome, 360 degrees subconjunctival hemorrhage, some blood, and the orbit is very, very tight. If you do CT scan, this is what you see. At the end of the lecture, I will tell you in the court what to do. It's an urgent decompression. We'll talk about it at the end of the lecture. Now we go back to what we have to talk about today after we talked about the anatomy and the trauma. Eye injuries in basketball, evaluation and management. Basketball is one of the most high-risk sports for eye injuries. It's estimated 6,000 basketball eye injuries annually. 100,000 sports-related eye injuries are yearly, with 13,500 resulting in permanent loss. I'm trying to do something on my computer. I'm not able to. I'm getting one of the, I don't know. Okay, we're fine. 90% of sports-related eye injuries can be prevented with protective eyewear. All athletes, professional or hobbyists, should prioritize eye protection. A functionally one-eyed athlete should wear appropriate eye protection in all sports, including basketball. The eyewear should be a protective eyewear using polycarbonate lenses, because the polycarbonate, if they break, they stay in there. They don't break into the eye, they break inside themselves. 2018 study found basketball responsible for almost 16% of eye injuries in kids. The common basketball-related eye injuries include orbital fractures, eyelid lacerations, and corneal lacerations. We'll repeat them in a while. Injuries more likely to happen in the fourth quarter, and the offensive players in 50% of time was caused during offensive plays in 50% of the time was caused by opponent. 16.7% times was caused by the teammates. Another epidemiology, basketball-related injuries are the most prevalent among sport injuries, in 31.6%, with 1.44 eye injuries per 1,000 games among professionals. I'm repeating it, that most common injuries include eyelid abrasions, lacerations, periorbital contusions, and corneal abrasions. Most injuries result from another player's fingers or elbows rather than the ball itself. I'm sorry, just asking, are you seeing my screen?
No, Ibrahim.
I'm sorry, just checking it now.
Yes,
And now,
back on. Thank
okay,
you.
I'm
Yep,
sorry what
thank
happened.
you.
All right, great. Coming back. Now, okay. Shall I continue or you want me to repeat the...
I think we'll continue at this stage, and we've got plenty of time for questions coming up at the end of the session. Yeah.
It's important for any medical doctor with the national team with clubs to have an eye kit with them. The eye kit includes a vision chart, a pen light, a light source, a fluorescein dye, cotton swabs and gauzes, contact lens remover, eye shield, and sterile saline. You should do a vision test for each eye separately when you have a trauma, in addition to confrontation visual field testing. Referral is needed if there is decrease or loss in vision or loss of visual field. With the pen light, you look for pupil reflex. This is if there is no light, the pupil is slightly dilated. When you put light, the pupil should be constricted. If there is anything abnormality with the swinging light in the pupil, that warrants a direct referral. Why I'm putting this, I don't want to do, I'm not doing commercial for this eye drop. These eye drops are anesthetic. Because we don't use it a lot, it's important to look for the expiry date, because you don't want to use any anesthetic with that has been expired in the eyes of our athlete. Because this eye drop, when you open it, in 1 month you have to throw it. You cannot keep it. It may cause allergy for the players. So always, as a doctor, look for the expiry date of the eye drop. The way we put the eye drop, we let the player looks up. We can pull the lower eyelid a little bit without pressure and put the eye drops. When we put it, we examine the anterior segment, the cornea, see if there is blood, as we talked about. We refer if there is blood in the anterior chamber. These are the 3 patients we talked about that we do not need to refer. If there is hemorrhage with normal cornea, the vision is good. The visual field is good. He even can go back to play. Corneal abrasion, with your pen light, you put fluorescein, and this is what you see. If it's a closed globe and you need the player urgently, then you can put for him a contact lens, put an eye drop for him, antibiotics, and he can go and continue the game, and then you can refer him to an ophthalmologist. These patients, you cannot let them go back to play. High FIBA, retina and choroid in the sclera is ruptured, 8-ball high FIBA, 360 subconjunctival hemorrhage, lens in the anterior chamber, abnormal pupil. How we evaluate also. So we put the eye drops, we look at the anterior chamber, then we look for the motility of the eye. We let the patient look to the right, look to the left, look up or down. Any painful movement, any restriction, any double vision, then we have to think of soft tissue injury or bone fracture, as we talked earlier in our talk, and it warranty a referral. Look for the skin. If it's only skin, we said we can suture, send to the court. If it's hard, then we have to refer to non-oculoplastics. What is an orbit compartment syndrome? So the player got a big trauma, 360 subconjunctival hemorrhage. You put your hand on the eye and you see that it's very hard, and he tells you, I'm losing vision. at the court. I think most of anterior ophthalmologists or ENT or plastic surgeons, they know how to do that. You give some anesthetic, you do a skin incision, and then a deep incision until the fat, and then you release the eye from losing it in like half an hour. This is emergency. We teach it to our medical students and to our residents how to do that. Last few slides. What are the signs and symptoms of vision-threatening injuries that require immediate referral? So any sudden decrease or loss of vision, any loss of visual field, any pain with eye movement, any photophobia, any double vision, any proptosis or inophthalmos, any light flashes or floaters or irregular shaped pupil, any hyphema, any embedded foreign body, any halos around lights, any laceration of lid margin or medial, any suspected globe perforation or 360 subconjunctival hemorrhage. Now, when can we let the patient go back? If he has corneal abrasion or if foreign body, if no functional or binocular vision loss, he may return to play. Any subconjunctival hemorrhage, if minor or no symptoms, and the vision is good, he can play. All the others that we talked about, he cannot play. Hyphema, orbit fracture, blood, retinal injury, grope, or eyelid laceration. When to use protective eyeglasses? The protective eyeglasses are made of polycarbonate glasses. Important to tell the players and the doctors, the contact lenses will offer no eye protection. All athletes who are monocular, which means they have only one eye, the other eye they cannot see with, or patients who have done refractive surgery to remove the glasses following LASIK and not normal PRK, the normal photorefractive surgery. These patients, they need to use polycarbonate glasses. Okay. The problem comes now. Why do not all athletes then use polycarbonate glasses? Because using glasses during basketball games for professional may affect their peripheral visual field and may affect their performances. So this is a very important slide to keep in mind for these patients. Very important on the courtside evaluation. If you have an open globe injury is suspected, do not put a pressure on the globe. You will harm him and harm the eye maybe permanently. Very important to keep an eye shield for you, put eye ointment, antibiotics, and use an eye shield to protect the eye. Thank you.
Thank you very much, Ibrahim, for this great presentation. We now open the floor for questions. So you can either use the hand raise button or type your question in the chat, and we will give you the floor. Maybe, Pete, you can control the traffic here. Thank you.
Thanks. Charo has a first question. I'd like to know your opinion about the evaluation of vision of the basketball players pre-participation, please. Ibrahim?
Yes, I'm sorry, I didn't hear the...
Oh, the question was, Charo asked, what's your opinion about evaluation of vision in basketball players as a pre-participation?
So you mean before the games they have a vision?
But when they start with a team or when they first join a team as a baseline set of tests, would you do that in all players? Would you do that in players who have visual problems or what?
Usually not, except if they have a player who is high myope. High myope, they have a high myopia, or a player who have undergone surgery for the LASIK, they refer them for an eye evaluation before going to the games. But it's not a routine to do that.
Does anybody else have any other questions? Charo?
Thank you, Peter. Congratulations, Ibrahim. My question is about the pre-participation medical check to the players, because I think for me it's very important your presentation when you have a medical an injury or a concussion or different problems during the game, but not only during the game, it's during the training too. And some players don't have a good vision. They have problem with the lateral vision, and they can affect their performance. I don't know if you have or follow a protocol to do that before 1 time per year. I don't know what is your opinion about this. Thank you.
So you mean to have a protocol for the players to have a visual field and the vision before the games? John, am I right? So that I will know how to answer, Captain.
Not again, sorry, not again. Normally we check the heart, we check the vertebra foot before to begin the season. In a medical check before the season, perhaps doctor don't pay enough attention to the vision or eyes evaluation. I'm telling you about if you have a graduation of your eye, a campimetry to know, yes, because in some cases can affect to the through, for example. Thank you.
I think it can be related to the same question that Peter was asking about examining the players before practices, before game. In our clubs where I'm really involved, we don't do the eye examination. We go for the heart, we go for the psychiatric things. We never had this protocol. I don't know if as a committee we want to include that in. I don't know if it's cost effective, if it's worth it.
Yeah, I think we can take that offline and as a commission work out whether that's something we want to look at. But it's a really useful idea, isn't it? Peter Harcourt had a question regarding eye injuries. Are there any eye injuries, common eye injuries, where a player wouldn't be able to fly? So we might be in one city or one part of the world, and we have to fly to another destination. Are there things we shouldn't allow our players to fly with?
If it's an open injury, it's better not to fly. It's better to work it directly. Even if you don't have a professional, professors in doing such surgery, any eye doctor can just suture the wound, and then he can travel and he can go to a more specialized areas. So an open globe should not travel.
Okay. Could you speak about viral infections of an eye and what we should be alert to?
Well, this is a big problem because, like the corona, any viral infection is contagious. So if one of the players have a red eye with a discharge and he plays in the game, there is a high possibility that this player will affect all other players, and I think it should be the responsibility of the doctor of the team not to allow this player to participate, because viral conjunctivitis is it's really contagious.
Pete, did you have a follow-up to that, or is that going to be part of our work that we're going to be doing on infectious disease by the sounds of it?
Yeah, I mean, it's a tricky one, isn't it? You know, because sometimes viral illnesses of the eye can actually be threatening to the eye itself. It's a question of how you treat them. I suppose you'd have to get a specialist opinion about it pretty quickly.
Hmm. Any other questions for Ibrahim?
Just a quick question, Ibrahim, if you're going to suture around the eye, what sort of material do you use, and what size?
It depends if we are suturing the cornea or we are suturing the sclera.
The skin.
Okay. The skin. I have it in my slides. It's 50260 silk. Yeah. Silk 50260. And this simple laceration, just put a steady strips, and then he can go back to sports, and then you can suture it later on 50260. But if in the eye, the cornea, we suture it with 10-0 nylon. I know, and the sclera with the vicryl 680 vicryl.
Yeah, I was just having a bit of anxiety when you talked about operating on the cornea.
My God.
Are there any final questions for Ibrahim?
Well, I think the kit, I have to make it like the full kit. If I send you pictures, and this picture should be sent to all the medical doctors who are in the team, and just give them like simple things how to use it. I think it's important.
Look, your presentation has been wonderful. Thank you so much for the energy, for the expertise, and the way it flowed as well. It was a great presentation, Ibrahim, and thank you very, very much on behalf of the Medical Commission for presenting today. For those of you who are new to these sessions, we record them and we will be putting them up on our new website, which is coming up in the next 4 weeks. And there'll be many other different webinars available for you to watch, as well as other content. If you've not been part of this group, but are interested in being part of the broader email connection, then please reach out to Linda Voigt, who's our manager with the Medical Commission, and that'll give you an opportunity to have access to things like the Fast Break, which is our quarterly journal that provides updates on basketball-related sports medicine, and as well as guest editorials on many different topics. It's an opportunity for you to connect with your clinical colleagues around the world. And just another heads up, on the 9th of December, we have another session on acute injuries in basketball. A couple of Kiwis from my hometown, a professor of maxillofacial surgery and a senior lecturer in ear, nose and throat surgery, are both very passionate and very practical people, as well as Ibrahim, and so that'll be happening on the 9th of December, so please put that in your diaries. But on behalf of the Commission, I'll hand over to Chin. Chin has a question or comment.
Yeah, actually I wanted to ask, because Ibrahim, the eye has a lot of movement, the eyelid and the skin is loose. So when we have a laceration, I think if we think we cannot oppose it properly, because especially it's on the face, and maybe I'm partial, maybe women, maybe men also want to look good, but women also, So if we think we are not confident to oppose it properly, then we should send it to maybe the oculoplastic doctor or the plastic surgeon to stitch it. If it cannot be done, we think we cannot do it properly. Is it correct? Yeah. Because there's a lot of movement depending on which part of the eye is being lacerated on the skin.
Yeah. Any patient who has a lot of movement, when you put the anesthetic in his eye, he will feel relaxed because he will feel nothing and the movement will decrease.
Okay.
If he keeps on moving, just put ointment on the eye, put the eye shield, don't patch it, and send him to the eye doctor.
Okay. Okay. All right.
Ibrahim, we have a question here. Which is the best eye drops for using during the game? Of course, during just pain and not huge trauma. I mean, for pain relief and for antiseptic. We use it a lot.
Okay.
But it'd be very interesting to see what you think.
Well, in Lebanon, we are stuck with 2 medications because the others, they don't come to our country. So any anesthetic, you can use it. The problem is don't overuse anesthetic eye drops. It will harm the cornea. And it's very well known. This is in the literature. If you give the patient anesthetic at home and he has pain and he uses it for 2 days, like every 1 hour, he may have decompensation in his cornea and end up having a corneal graft. So any you have two medications with you. Anesthetic, you use it once, maximum twice. Any kind of anesthetic, you put 1 drop. You don't have to put many drops. The eye will take 1 drop. And then keep an eye ointment which has antibiotic in it. Whenever you put an eye drop or antibiotics, don't pull the eye from up. Let him look up, pull the lower eyelid. Don't put pressure in the eye. So when you put it, if he has an open globe, you are not going to harm him.
Ibrahim, is there ever a place to use an anesthetic eye drop, in your opinion, during a game? And my second question is there ever a place for a primary care doctor carrying corticosteroid eye drops for eyes?
Well, anesthetic can be used, and we give it to the doctors in the game. They can open it and they throw it because it's only 1 month. He can use it once or twice. They should not use any steroid eye drops, because if they have a corneal abrasion and you put steroids, then you are decreasing the healing of the abrasion. Did I answer right? This was your question.
Yeah, no, it's exactly what my teachers have taught me many years ago, and obviously the message hasn't changed. We had a question. Thank you for the presentation. Any eye drops that you should avoid which potentially produce adverse results in anti-doping tests?
Well, we know that if you use eye drops, the possibility of that being transmitted into our body with the lacrimal system and causing high blood levels is like almost not found, minimal. So an eye drops should not affect. Now, I didn't look in the WADA prohibited drugs, but I didn't see any eye drops in that.
Okay. Right. Any
Sorry.
Chin?
Yeah, I can make a comment on just about that. Yeah, you're right, Ibrahim. Most of the substances that are applied topically to the eye, they are typically not prohibited. Yeah, okay, but please check. All right, please check anyway on the list. But it will classify that and say, if it's otic, so if it's a glucocorticoid that is an eye drop applied like that, that is not banned. But if a glucocorticoid done in any other form, you take it, that's banned. Okay, yeah. So please check. Yeah.
Linda?
Yes, just take the opportunity here. I know you're all very familiar with the tool, but it's always worth checking on Global Draw to make sure that if there's any substance that's part of the composition, it's always a safe tool. So to bounce on what Chin Sim just said, always check, and Global Draw is a good reference to check for if it's any substance that are concerning and part of the prohibited list.
Any more questions? Okay, well, look, on behalf of the Medical Commission, and everyone attending. Thank you, Ibrahim, for your session, wonderful session, and thank you all for attending. Please reach out to your colleagues and continue to evolve, and thank you very, very much. Have a good day, good morning, good evening.
Thank you. It's nice seeing your faces again.
Thank you very much.
Goodbye.